Good evening, everyone, and welcome to NCODA's Student Educational Talks for this month of May. I'd like to go ahead and start off by reading our professional student organization mission statement. Our focus is to offer an international community for healthcare students with passion in oncology and pharmaceutical industry. We provide education, leadership, mentorship, and opportunities in research and community outreach. We promote unique and dynamic experiences for students to collaborate with all oncology stakeholders. First, I'd like to welcome all of our established NCODA professional student organizations: South University, University of Rhode Island, Midwestern University, North Texas University, Washington State University, Texas Tech University, Purdue University, Nova Southeastern University, Massachusetts College of Pharmacy and Health Sciences University, University of Minnesota, University of Toledo, Albany College of Pharmacy and Health Sciences, University of Iowa, Lake Erie College of Osteopathic Medicine, Auburn University, University of Missouri, Kansas City, Binghamton University, University of New Mexico, Belmont University, Wingate School of Pharmacy, University of Florida College of Pharmacy, University of Utah College of Pharmacy, Howard University College of Pharmacy, Temple University, Shenandoah University, Oregon State University, the University of Toronto, and the University of Colorado. Welcome, and we look forward to having you join us this evening. Next, I would like to welcome all of our in-progress NCODA chapters. We thank you for us, and we enjoy expanding. Welcome any and all students listening in. NCODA will be providing student educational talks to all students regardless of membership, and they'll all be recorded and placed on our website following this presentation. NCODA is growing by leaps and bounds. We are now 3,400 plus members and 540 practices strong. Working together, we become stronger. Stay up to date on all NCODA student events and resources by following the NCODA Professional Student Organization Facebook and Instagram page at facebook.com/NCODA Professional Student Organizations, or use the camera on your phone and scan the QR codes now. Also, don't forget to follow NCODA's national LinkedIn page for any and all updates. Next, I'd like to welcome you all to our first ever professional student organization meeting. It'll be held September 16th and 17th in Detroit, Michigan at the Westin Detroit Metropolitan Airport. This is an opportunity for all students to connect with key leaders in oncology, NCODA industry sponsors, and fellow peers as you discuss an oncology pharmacist journey as you prepare for your futures. Some of the keynote speakers that will be invited for this meeting will be Tim Whitten, the CEO of Taiho Oncology, Lori Pierce, the president of the American Society of Clinical Oncologists, as well as current residents, fellows, and numerous other presenters. So we look forward to having you there, and go ahead and put it on your calendar, as we will be in person with a hybrid option for anybody who isn't able to attend. Now, I'd like to turn it over for our first presenter of the evening, Mi Lin, and she's going to be presenting on the management of acute transfusion reactions.
Hello, thank you everyone for joining us this evening. Like Austin said, my name is Mi Lin Oh. I'm a P4 student at the University of North Texas Health Science Center, and tonight we'll be talking about the management of acute transfusion reactions. Next slide. All right, as far as the contents of my presentation, we're going to go over the use of transfusions, statistics regarding transfusion reactions, the types of acute reactions, the management of said reactions, and then the prophylactic management of transfusion reactions. Next. All right, to start, what are transfusions? So this is going to be the use of whole blood or a component of whole blood for patients who need a little bit of help. So it supplements the body quickly from insufficient levels of whatever product you're using. As far as the reactions, acute reactions in particular occur within 24 hours of a transfusion. They're going to be used in a variety of patients, not just cancer patients. They can also be used in sickle cell disease, hemophilia, anemia, and for trauma. Next. All right, let's go over a little statistics. So about 4.5 million patients will need blood transfusions per year. Why does that matter to us? Well, for cancer patients, they use about 1/4 of the nation's blood supply in transfusions. The reaction rates for all transfusions are going to be 282 per 100,000 units. Next slide. All right, so what are we looking for with transfusion reactions? So things that we're going to be looking for are we're going to be monitoring for changes in the patient, such as tachycardia, the hypo or hypertension changes, changes in temperature, such as like fever, chills, alterations in consciousness, itching with any part of the body, and then difficulty breathing. We're also going to be making sure we monitor these patients for at least during the first hour every 15 minutes. Next slide. All right, let's go into the different types of acute reactions. We're going to first start with trolleys, so transfusion-related acute lung injury. So this is going to be new acute lung injury within the first 6 to 24 hours of blood product administration. Now, this is pretty rare. It happens in 1 in about 12,000 transfusions, but it is the second leading cause of mortality for acute transfusion reactions. So this is going to be caused by neutrophil-mediated damage to the pulmonary microvasculature. So the management is going to look like respiratory support since this is lung injury. So this can be supplemental oxygen, this could be intubation, this could be the use of BiPAP or CPAP. All right, the next one we're going to talk about is my favorite. It's called TACO. So transfusion-associated circulation overload. So the cause is if you get way too much fluid in you and you have too much volume circulating. And this can lead to peripheral and pulmonary edema and just too much work on your heart. So for management, you're gonna discontinue the transfusion. And the two ways you're gonna remove fluid is either diuretics or a controlled phlebotomy. I don't know any practice sites that really do controlled phlebotomy. So diuretics such as Lasix are going to be your first line option for these patients. Now, this is important because this is the highest cause of morbidity in transfusion reactions. So we're going to want to keep a close eye out on these patients for any changes in the blood pressure or headaches. Next. All right, next we'll move on to acute hemolytic reactions. So this is going to be caused mostly from ABO incompatibility. So the lysing of the blood cells will cause your symptoms like your back pain, your flank pain, chills, fever, and dizziness because of the release of all the cell contents that are being lysed. So management for these types of reactions are going to look like aggressive hydration to prevent AKI in these patients. And then we're also going to monitor and correct for any cardiac arrhythmias that may occur. Next. All right, the next one is going to be bacterial contamination. As we can probably assume from the name, this is caused from impure transfusion products that contain foreign bacteria, whether it's the blood itself or one of the appliances that are used, such as maybe like the needle or the tubing. So the management is going to look like discontinuing said transfusion, getting appropriate blood and tubing cultures to see what grows, initiating appropriate antibiotics. We're going to go a little bit broad for this, such as bank plus a beta-lactam or aminoglycoside. And then once you narrow down the actual drug or bug that's growing, you can narrow down your antibiotic therapy appropriately. Next. All right, here we are with non-hemolytic febrile reactions. So the cells are not being lysed, but you're still getting fevers. So this is going to be caused from the preformed cytokines that are stored in the blood products interacting with the patient's own immune system once the blood is in there. So management for these patients are going to look a lot like fever control, but we're also going to want to avoid aspirin due to its antiplatelet effects. All right, now we're on to allergic reactions. So the cause is going to be your immune system interacting with a part of the transfusing product. So for mild, this is pretty common in patients. There's some itching. So we can manage this by decreasing the infusion rate, plus or minus the use of an antihistamine, just to help with the itching a little bit. And on the more severe scale, got anaphylaxis, which I'm sure many of us are familiar with treatment of. So you're just going to go with your algorithm at whatever facility you're with. Normally, you can do epinephrine or norepinephrine, depending on what your facility goes with, and then with or without a steroid and or antihistamine on board as well. All right, so prophylactic management. So for patients that you know, like they will have a transfusion reaction because they've had it before, then there's going to be some things that we can do beforehand to stop it from happening again. So many institutions will have their own protocols on transfusion prophylactics for patients who have a document allergy to those products. This will often include a combination of medications. You'll often have an antipyretic. Normally this looks like acetaminophen, an antihistamine, your diphenhydramine, with a corticosteroid. Normally this is going to look like methylprednisolone. All right, in practice, why are we doing this? Why am I talking about this to us? So having safety protocols for how to manage reactions is necessary. All providers, no matter who you are, knowing what to look for and how to manage transfusion reactions is a part of oncology practice. As most likely, there will be at least one patient that will walk through past your care and they will have some type of transfusion reaction. I really think that training for all staff involved with transfusions can help decrease complications from an infusion reaction. Truly, like during my own care, I had a transfusion reaction and it was not handled in the most appropriate way. So I'm a huge advocate for education for all members of the staff. I believe that brings me to the end of my presentation. Thank you so much for listening, and the next slide will have my references.
Thank you, Milan. And now if there's no questions, or if somebody wants to put in questions into the chat box as we continue, I would like to kind of introduce our next presenter for the evening. So our next presenter is going to be Dr. Shalin Kathari, and he is the Assistant Professor of Medicine in the section of Hematology in the Department of Internal Medicine at Yale University and their hospital. And now I'd like to turn it over to you, Dr. Kathari.
Hi, Austin. Thank you for inviting me for today's talk. So I'm going to talk on advances in the treatment of aggressive B-cell lymphomas. Next slide. So right before we dive in, aggressive B-cell lymphomas are essentially diffuse large B-cell lymphomas, mantle cell lymphomas, and other miscellaneous transformed lymphomas that arise from indolent lymphomas. But today, for today's presentation, I'm just going to focus on diffuse large B-cell lymphoma and mantle cell lymphoma. and just talk about the latest FDA approvals in the last 1 to 2 years. Most of these approvals were actually in the last 6 months or so. So very exciting new stuff in our field. For diffuse large B-cell lymphoma, I'm sure pharmacy students would be aware of, the classic regimens of R-CHOP and other regimens that are commonly used. But in the relapse refractory setting, so once patients stop responding to those regimens and they have a relapse, then the novel drugs come into play. One of them is polatuzumab vedotin, which is approved now in combination with bendamustine rituximab. The second is tafasitamab, which is approved by FDA very recently for use in DLBCL in combination with lenalidomide. And loncastuximab tesirine, which is the latest approval. And I'll talk about these agents in detail in just a bit. And the last is selinexor. Next slide. For mantle cell lymphoma, oh, did you skip one slide? Sorry. Okay, maybe it's in the later part. So for polatuzumab vedotin is a CD79B targeted antibody drug conjugate, which delivers a microtubule inhibitor. As you can see on the right, polatuzumab vedotin is shown with various sites of linkers with an MMAE attached to that linker. So once it is internalized in a tumor cell, it undergoes processing through endosomal and eventually proteasomal degradation and even lysosomal degradation, and releases the microtubule inhibitor, which is the MMAE. As people might know, that CD79B is ubiquitous on the B cells. So it is a very attractive target to target B cell malignancies. And one of the research papers showed that more than 95% of DLBCLs would be CD79B positive. Next slide. So the reason to show this slide is just to show how complicated this regimen was. So the way it was designed was they had a first phase 1B safety run-in, followed by phase 1B2 expansion and phase 2 randomized component. So the run-in phase was with polatuzumab, bendamustine rituximab. The 1B2 expansion phase was with polatuzumab, obinutuzumab, and bendamustine. And the phase 2 randomized trial was with 2 comparators of just BR and the other one being polatuzumab with BR. The only thing I would like to point out is that the median age of all these patients in all these arms was around 60 to 65, except for in the BR arm, which was a slightly elderly patients. And if you look at the stratification factor in somewhere in the middle, you will see that duration of response of last treatment within the last 12 months, there is quite a bit of a difference between the phase 1B2 expansion group and the phase 2 randomized group. So you see that there are 23 months of duration of response of last treatment versus 32 and 33 in the phase 2 randomized part. Next slide. These are the survival curves of the trial. So you can see the one in blue is polatuzumab, bendamustine rituximab, so the experimental arm, and red is bendamustine rituximab. And this is, of course, only looking at the randomized phase 2 part of the trial, which had 40 patients in each arm. You can see there is a clear PFS, which is shown in figure A, and figure C, which shows overall survival. So, these are one of the rare trials that we have recently seen in aggressive lymphomas, where we see an overall survival advantage of a regimen. So, clearly a winner when it comes to polatuzumab in comparison to just bendamustine rituximab. And something interesting, at least from the scientific side of things, that there was ubiquitous expression of CD79B, as we previously talked about, but there was no correlation noted between CD79B expression and the level of response. So that's something that we still don't understand why that would be. So further research is needed for that. Next slide. So these are the adverse events, which I thought would be interesting for this audience, where if you look at the polatuzumab bendamustine rituximab arm, there are clearly, definitely more anemias, more grade 3 and 4 neutropenias than in the BR arm. And as I show on the left, on the right, there was use of GCSF was permitted per investigator's discretion. And interestingly, given that it was in investigators' hands, more investigators used GCSF in the POLA BR arm than in BR arm. So that may explain the discrepancy between the lack of increase in febrile neutropenia in the POLA BR arm, while there were more neutropenias. Next slide. The next regimen, or rather the next drug approval that I want to focus on is tafasitamab, which was approved in combination with lenalidomide. So tafasitamab is an FC-enhanced humanized anti-CD19 monoclonal antibody. So it just like any other CD19 monoclonal antibody is going to mediate ADCC and also antibody-dependent cellular phagocytosis. And of course, it also exerts direct cytotoxicity. If you can see on the right that the engineered FC portion is shown in that circular figure in as a part of the monoclonal antibody, which actually further enhances the ADCC and ADCP of this molecule in comparison to ubiquitously used rituximab. So this is approved in combination with immunomodulatory agent lenalidomide, which leads to increase in anti-tumor effects both in vitro and in vivo. Next slide. So this was the regimen called L-MIND, which was a multi-center, multi-nation prospective single-arm phase 2 study of this particular regimen. And as you can see, I'm just showing one of the figures here where the complete responses in this trial were 43%, which is phenomenal for such an aggressive disease, and one of the highest that we have recently seen in this disease. And PET confirmed complete responses were 88%. So out of those 34, which is pretty impressive. Next slide. These are the curves, survival curves again, as you see on in figure B. You see proportion of patients with complete or partial response. So the one in dark blue is complete response, lighter blue is partial response. And you clearly see that patients who had complete response continue to enjoy disease-free time, versus patients who had partial response, they continue to eventually progress. So when I use this regimen in clinic, I'm very anxiously waiting for the end of treatment PET scan to see whether the patient has achieved a complete response or not. In figure C, you see progression-free survival, and the median PFS is around 12 months, which is again the highest that we have seen in such heavily refractory relapse patients with diffuse large B-cell lymphoma. In figure D, you see overall survival, which is also shows a significant advantage to using this regimen. And you also see what we call a tail effect. So many of these patients who survive and who enjoy a good response from this regimen continue to enjoy beyond 2 years, which is great. So this is definitely a very exciting regimen that we use now more and more frequently in clinics. Next slide. These are the toxicity profile of this regimen. very, very well tolerated regimen, hardly any serious side effects. Of course, as you see here, there were grade 4 neutropenias, but if you look at the febrile neutropenia column, row rather, you see that the grade 3 were only 10%, which is relatively decent for regimens in relapse refractory DLBCL setting. And all the non-hematological events were not that significant, and most of them were grade 1 and 2. Next slide. The third drug that I want to focus on is loncastuximab tesirine, formerly known as ADCT-402. That's an antibody drug conjugate comprising, again, the same humanized anti-CD19 antibody. So again, we are targeting the B cells, but this time with a different cytotoxin. So we are using pyrrolobenzodiazepine dimer, which is the payload is attached to the monoclonal antibody in fashion that is shown on the right in the figure. It is rapidly internalized by CD19 expressing cells, and then, as we can imagine, the payload gets released, which causes intrastrand DNA crosslink with minimal DNA distortion, which might contribute to the persistence in cells through evasion of DNA repair. So this regimen, this drug was approved like literally 3 weeks ago by the FDA, and it's so fresh that I still don't have this drug in clinic. But I have a few patients lined up who would benefit from it. So we are currently working on getting this drug in the clinic. Next slide. This is the trial that led to the approval of this regimen, LOTUS-2, which was a multi-center open-label single-arm phase 2 trial. As you can see, the complete response rate was a decent 24%, with overall response rate, which is the combination of complete and partial response, which was 48.3%. So, quite encouraging numbers. Next slide. These are the survival curves on, again, kind of following the same theme like other regimens, where in figure A, you see patients divided into whether they achieved a complete response, partial response, or both. And the one in green is both, which, for obvious purposes, it falls in the middle of the other two. And the one in red is patients who had partial response. So again, the same theme where complete response is a good marker that this regimen that this drug is going to be beneficial for the patient. As you can see in figure B, these are progression-free survival curves. Again, not similar to tafasitamab and lenalidomide, where you see that tail effect. But this, you still continue seeing progression as months go by. But definitely something that few of my patients would benefit from, especially if I am getting them ready or if I'm waiting for a clinical trial to open up, which would be beneficial to them. In figure C, you have overall survival data. Again, as you can see, very little tail effect, and that tail effect may be from the fact that they may have received other regimens after this particular drug. So difficult to interpret the tail effect of this overall survival curve. Next slide. These are, again, the adverse side effect profile of this drug. Definitely some more side effects, especially grade 4 neutropenias, as you can see, 16%. But again, the same theme follows, that the febrile neutropenia rates were very low. So most likely these patients would have received some GCSF support. There was definitely some nausea and fatigue, which I have heard from other investigators who are on this trial, that can become an issue, but here at least it's reported as only grade 1 and 2. So that's something to just be aware of. Next slide. Selinexor is the fourth and the final drug that was approved by FDA recently, and with a very unique and novel mechanism of action. So it's an XPO1, exportin-1 inhibitor. And XPO1 is one of the 8 nucleocytoplasmic shuttling proteins. It's shown in red in the figure on the right. which is involved in export of proteins from the nucleus to the cytoplasm. So these are the proteins, like tumor suppressor proteins, or even oncogenic proteins, oncoproteins, such as MYC, BCL2, BCLXL, the list goes on. So if the idea was that if you're able to keep oncoproteins kind of stuck in the nucleus by inhibiting this particular protein, then you would prevent a cellular proliferation and hopefully cell death in cancer cells. Next slide. SADAL was the name of the trial that led to approval of this regimen in diffuse large B-cell lymphoma. It was a multinational, multi-center, open-label phase 2 trial. And as you can see here, definitely weak data in comparison to other regimens. So you see complete responses in 12% of patients and oral response only in 28% of patients. So overall, nothing compared to the other regimens. Next slide. This is the side effect profile, and I want to definitely focus on this if you end up seeing somebody on this drug, and look at the degree of nausea, and where is vomiting? Vomiting is somewhere in the middle, but the nausea is quite a bit. 52% of patients, so half of the patients had grade 1 and 2, and then the other 6% had grade 3, which became a major problem in this trial. And vomiting, as you can see here, is 30%, and with grade 3 vomiting, 2%. So when this drug was approved and once we started using it in clinic, we realized that the real world data was probably even more. All of my patients developed nausea and vomiting from this drug, to the extent that now it is recommended, as per our expert guidelines, that we should use 2 anti-nausea medications continuously while the patient is on this drug. So it's not a very easily tolerated drug, to put it in nicely. Next slide. These are the survival curves. The progression-free survival, median PFS was 2.6 months, which is again I'm definitely comparing cross trial, which is not the best thing to do, but that's what we have. That's the only data that we can go by. On the right, it's never a good thing when you're reading a manuscript and you see survival curves as a supplement. It should be in the main manuscript. So that clearly shows that they were trying to kind of not highlight this data. But in figure S2, you see all patients who had a CR or PR, then stable disease and progressive disease. And as you can see in the CR or PR group, definitely patients who had a complete response did enjoy the tail effect, which means they continue to enjoy it even after our arbitrary threshold of 2 months. Next slide. So I'll focus on mantle cell lymphoma, which is one of the aggressive B-cell lymphomas. The hallmark feature being translocation 1114. So the recent approvals were of brexucabtagene autoleucel, also known as Tecartus, which is one of the latest CAR T-cell products. And then, although it's been a while that these drugs have been approved, the covalent BTK inhibitors are commonly used in mantle cell lymphoma. The poster child being ibrutinib, and then recent approvals of zanubrutinib, and slightly before that acalabrutinib, which are slightly more selective BTK tyrosine kinase inhibitors. Next slide. So brexucabtagene autoleucel essentially is a CAR engineered T cell with a CD28 co-stimulatory domain, and 3D CD3 zeta internal arm. As you can see, SVFC is shown on the top, which essentially is able to detect CD19. But the only difference when you compare this particular CAR-T product with Exa-cel, which you may have heard of, which was the first CAR-T cell approved for lymphomas and ALL, the difference between the Exa-cel and Brexu-cel is that the process of T cell enrichment was changed, because in mantle cell lymphoma and other lymphoid malignancies, you will have leukemic involvement of these cells. So when you are extracting the T cells for engineering, you can inadvertently end up getting those malignant cells also. So they basically had the difference in brexucabtagene is that they have a T cell enrichment phase. It was incorporated into production of this product. And manufacturing was done without the use of beads or antigen presenting cells. So they were able to make a product with a very high percentage of T cells, more than 99%. And this didn't add any further time to manufacturing of the CAR-T cell product. Next slide. This is the trial that led to its approval, led by Michael Wong at MD Anderson. It was previously known as KTE-X19. And as you can see here, median age of 65 with age range of 38 to 79. What I want to focus your attention on is the TP53 mutation part, where you have 17% of patients with TP53 mutation, which is considered a very poor prognostic sign. And usually these patients would have a very rapidly proliferative mantle cell lymphoma. The other thing I want you to focus on is the previous BTK inhibitor therapy. So 100% of patients, all patients, had a previous BTK exposure. So, that's phenomenal, because these are the patients who otherwise do very poorly, and we urgently needed something to help them. And now we have this particular CAR-T cell product. Next slide. These are phenomenal data. So if you look at the percent of patients who had any response, you see 93% of patients had some response. Out of those, 67% of patients had a complete response, and 27% of patients had partial response. So, very, very encouraging data. You can see duration of response in figure B with, again, a very good tail effect. And they didn't even reach their median, I believe. And the same held true for PFS and overall survival for the median. I'm not exactly sure of how long they followed these patients when this data was published, but at least until the data was published, the PFS and OS median was not reached. Next slide. Adverse effects amongst all 68 treated patients, as we expect with CAR-T cell product, any adverse event, all 100% of patients had, some adverse event, and the most common being pyrexia, which could have been part of cytokine release syndrome, neutropenia, thrombocytopenia, anemia. The grade 3 and 4s were definitely there, especially with neutropenia and thrombocytopenia. As we have seen with other CAR-T cell products, these thrombocytopenias, especially more than neutropenia, they are very long lasting. So it needs to be seen whether that holds true even with brexucabtagene. But the rest were pretty manageable. Next slide. So, I just wanted to quickly talk about future directions. We are expecting approvals very soon in these diseases, especially with something called non-covalent BTK inhibitors. One of the contenders is LOXO-305, also now known as pirtobrutinib, which has shown very promising activity in patients with CLL, with mantle cell lymphoma, who have relapsed after covalent BTK inhibitors. And then BiTE, which is bispecific T cell engager, like mosunetuzumab, glofitamab, and other newer generation of CAR-T cell products. We have multiple clinical trials ongoing at Yale University and YNHH. which is the hospital part of the university. And you're welcome to visit our website to check all the details out for the clinical trials and refer patients in case they would benefit from these clinical trials. So I would thank you for your attention, and I'm happy to take any questions.
Hello, my name is Madison. That was a great presentation. Thank you. I
Yeah.
do have a question for you. With all of these new medications constantly coming out, what do you look at as a provider to help you make medication choices for your patients?
Yeah, so then, the devil are in the details, right? So you have to kind of look at all these trials and see what their inclusion and exclusion criteria were, which I could not go over today, given, the 20 minutes time slot. But just to give you an example, for patients with in the selinexor trial, the SADAL trial, they did not allow patients who had a progression up to 90 days after since the previous therapy. So these were the patients who otherwise had a very slow growing DLBCL. So, if I encounter a patient with a slow growing DLBCL, which otherwise would fit the criteria for this trial, then those are the patients I would try to, use selinexor in. Versus tafasitamab lenalidomide had a more inclusive criteria, but they did not include bulky disease patients. Bulky, to me or any lymphoma clinician, means that there is one or two lesions in the body with lymphoma which is measuring more than 10 centimeters in size. So for those patients, I would use loncastuximab tesirine, because they did include patients with bulky disease. So just to answer your question, very briefly, it would essentially be looking at the inclusion and exclusion criteria of these trials to see the patient and how the patient in front of you fits particular trial.
That's perfect. Do you ever have a hard time personally keeping track of all the exclusion and inclusion criteria?
Well, now more, right? Until now, these 4 drugs, we had pretty, it was a pretty barren land of drugs, at least novel drugs in DLBCL. So this is a good problem to have. And, there are always, we can develop local guidelines with the pharmacy team or with other lymphoma clinicians so that it gets easier in your clinical workflow. But this is a problem that I would love to have.
Great. Thank you so much.
All right, we'll go ahead and we'll try to share this. I know we were having some issues earlier. But Linda, if you want to go ahead and try to share your screen one more time, we'll try to make it work. And if not, you can always do this next.
Very good. Can you hear me?
Yes, we can.
And more importantly, can you see my slides?
Do not see them on my side.
Okay. We will continue this next meeting with no technical difficulties. Thank you.
All right. Well, 1 second then while I pull up mine again. So thank you everyone for joining us this evening. I know we're ending a little short, but running into some technical difficulties. So Linda will be able to present on CLL for us next month, as well as followed by another presentation kind of covering some Genentech medications that help with CLL. So we'll be able to discuss Gavyza and Venclexta.
Yes, that's correct.
And so just want to thank you everyone again for joining us this evening. I know it's a little late, but thank you. I do want to invite you to our next student educational talks. That's going to occur on June 30th, again at 8 p.m. Eastern. So we'll be able to have a double Gen Tech presentation for that evening, as well as Brayna Rowan. She's a pharmacist out of Massachusetts General Hospital and the North Shore Cancer Center. She'll be able to give us a presentation over MDS. So I look forward to seeing you all at that presentation. And if you haven't already done so and put it in your calendar, don't forget about our professional student organization meeting, September 16th and 17th.